From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, my name is Dr. David Simel, and I'm an associate editor for JAMA. In this JAMA author interview, we will be discussing the topic of prediabetes. To address this important condition, we are pleased to be joined by Dr. Samuel Dagogo-Jack, who is a leading expert on the subject. Dr. Dagogo-Jack holds the A.C. Mullins Endowed Professorship and is chief of the Division of Endocrinology, Diabetes, and Metabolism at the University of Tennessee Health Sciences Center in Memphis. He is a past president of the American Diabetes Association, and he is the author of Diagnosis and Management of Prediabetes that appears in the April 13th, 2023 issue of JAMA. Thank you very much for joining us, Dr. Dagogo-Jack.
Thank you, Dr. Samuel.
I'd like to start with a question on behalf of my primary care colleagues and myself, and that is that the prevalence of prediabetes is so high that it seems like we normalize what are abnormal values. So let's go over the case definitions of prediabetes. Could you define those for us?
You are correct that the prevalence of prediabetes is overwhelming. Currently, prediabetes is defined in a number of ways. It could be defined in terms of the fasting glucose values, where we recognize impaired fasting glucose as levels lying between 100 and 125 milligrams per deciliter. Prediabetes may also be recognized using the formal 75-gram oral glucose tolerance test, and by that procedure, a 2-hour plasma glucose level lying between 140 milligrams per deciliter and 199 milligrams per deciliter defines a type of prediabetes known as impaired glucose tolerance, which is in contrast to the earlier type, which is impaired fasting glucose. And more recently, the American Diabetes Association has included the hemoglobin A1C test as another criterion for recognizing prediabetes. And in that test, the applicable numbers are 5.7% to 6.4% hemoglobin A1C. So these are a number of ways of defining the prediabetes problem.
You mentioned impaired fasting glucose and 2-hour glucose tolerance tests. It doesn't seem like we do those very much anymore outside of maybe gestational diabetes.
Correct. Outside of gestational diabetes and clinical research, the oral glucose tolerance test is grossly underutilized in clinical practice, which makes the fasting glucose test the test of choice for recognizing prediabetes among participants or patients who can be trusted to observe the requisite duration of fasting, about 8 hours at least, and no longer than 12, 14 hours. So the hemoglobin A1C test, which doesn't require any person to fast, becomes the most convenient test for prediabetes in contemporary practice.
In your review, you cited that about 1 out of 3 adult Americans have prediabetes, which to me makes me think everyone is at risk. But there must be some people who are at higher risk than others. So could you describe those who are at higher risk for prediabetes?
Yeah, the major recognized risk factors for prediabetes do overlap considerably with the factors for type 2 diabetes. And those include being overweight or having obesity as defined by the body mass index that WHO put out there. So the numbers of 25 to 29.9 kilograms per meter squared BMI would be in the overweight category, and BMI levels reaching or exceeding 30 kilograms per meter squared would define obesity. So individuals who carry excess weight are at risk for both type 2 diabetes and prediabetes. Older age, we are finding it's a predictor of increased risk for prediabetes. Individuals who are habitually physically inactive do carry a risk, as are those following an unhealthy diet. There is also a role for genetic predisposition, and we've observed prediabetes risk to increase among individuals who do have a family history of type 2 diabetes.
Dr. Dagogo-Jack, is there evidence that there are differences in the incidence of prediabetes associated with race or ethnic backgrounds?
The diagnosed diabetes rates differ from one ethnic group to another in a way that has been recognized for some time. And the general pattern has been that individuals from African American background or Hispanic, Latino, or Asian or Native American background are diagnosed more frequently at a higher rate with type 2 diabetes than individuals who are white. However, with regard to prediabetes, we are not seeing a similar pattern of ethnic disparities. In fact, in a nationally representative cross section in the Haynes study, the National Health and Nutrition Examination Survey, conducted between 2017 and 2020, there was no evidence of significant differences in the prevalence of prediabetes for persons who were from non Hispanic Asian background or who are non Hispanic Black background or Hispanic Americans compared with non Hispanic whites. The numbers range from about 36% to about 39% of those populations testing positive for prediabetes without any significant differences by race or ethnicity. It is important that we screen individuals regardless of their background for prediabetes so that we do not underserve any particular populations based on an incorrect impression that they are at lower risk and then overscreen those based on a belief that they are at higher risk. I think the screening recommendation should be applied universally to adults so that we can capture cases of prediabetes and intervene promptly to protect people's metabolism and cardiovascular system.
With so many people meeting the criteria for the case definition of prediabetes, is prediabetes actually a disease?
That's an interesting question. Prediabetes defines states of abnormal glucose regulation that lead to early elevations in plasma glucose above the normal range but below the levels required for diagnosis of diabetes. In this context, the technical term dysglycemia may be applied. And if we analogize this to dyslipidemia, where we know that unfavorable lipid profiles can be linked to cardiovascular complications, then we can understand dysglycemia a little bit better because the dysglycemia of prediabetes is also known to be associated with increased risks for developing certain complications, including eye disease, neuropathy, kidney disease, and cardiovascular problems. Thus, prediabetes is not a benign condition.
Okay, so you mentioned or you explained to us the three different tests to diagnose prediabetes. How do we actually implement those, and what are the recommendations for screening?
The recommendations come from two authoritative sources. The United States Preventive Services Task Force recommends screening for prediabetes every 3 years in adults aged 35 years to 70 years who have overweight or obesity. The American Diabetes Association has a broader recommendation in that individuals aged 35 years or older are eligible for screening regardless of risk factors. And I think that speaks to Dr. Simel's earlier allusion to how widespread a problem it is. And it looks like 1 in 3 American adults having it means most people would be at risk. And so screening in a broader context makes more sense than tailoring screening to the presence or absence of specific risk factors.
Well, once we identify a patient who has prediabetes, we're going to talk shortly about how you intervene. But how does that affect screening in terms of the rates of progression to actual diabetes? So, how many people a year will go from prediabetes to diabetes?
So that number is there in the medical literature, and it is derived from randomized clinical trials in different populations. And in the United States population, the rate of progression from pre-diabetes to type 2 diabetes averaged approximately 10% per year. So over the course of half a decade or so, a significant number of individuals with prediabetes would have progressed to type 2 diabetes. Interestingly, even those who have prediabetes but have not progressed to type 2 diabetes, we are finding the beginnings of some vascular complications that historically we used to associate with the presence of long-standing type 2 diabetes. So individuals who have not yet progressed to diabetes may harbor some complications that can be diagnosed using standard procedures.
Does prediabetes ever just disappear? Does it ever regress and go away?
So, glucose measurements being on a continuous scale, and individuals in free living life may lose or gain some weight, may exercise a little bit differently. So, when we do repeated testing of large numbers of individuals who were initially recognized as meeting criteria for prediabetes, we do see some fluctuations downward of the initial cut points. In other words, individuals who had prediabetes at initial evaluation may return with normal glucose values. The likelihood of that occurring spontaneously is low, and in the best data I reviewed, one can say at most perhaps 15 to 20% of individuals may fluctuate downwards. So the more determined trajectory is akin to one where the prediabetes tends to inch forward increasingly toward a diabetes endpoint.
Well, you mentioned weight loss and exercise, and all of us, including our patients, sort of inherently sense that losing weight when you're overweight is a good thing. And we all have a sense that a lifestyle intervention is important for prediabetes. Is my talking to a patient about diet and exercise a lifestyle intervention?
In some way, it is. It is the beginning of lifestyle intervention. But I think the casual conversations we hold in the clinic may not be sufficient to drive change. So, lifestyle intervention has been packaged into a series of steps that are taken that include specific targets for calorie restriction based on initial weight and the amount of weight that needs to be lost, a deliberate policy of increased physical activity with set targets of duration and frequency of the activity, a mobilization of self monitoring so that the individual becomes a partner in his or her health care. So we encourage use of food and exercise monitoring diaries. And this recording of physical activity and food intake has been shown to be an important instrument in clinical trials for predicting behavior change. And also, many of the participants in the diabetes prevention trials who had prediabetes at enrollment and who were being encouraged to eat right, exercise, etc., sometimes would hit a roadblock where the weight change is not being impressive or they are having other issues. And so we found that emotional and psychological support helps overcome some of those motivational and psychological barriers. So, along with the prescription of calorie restriction and increased physical activity, came a need for intermittent reinforcement of the great principles of why we're doing this and discussing barriers to adherence to the lifestyle interventions and ways to work around those barriers.
Can I refer a patient to a lifestyle intervention, or is that just something that each individual clinician has to figure out for themselves how to coordinate?
Right. So there is the ready opportunity if you have a dietitian in your practice group to outsource this particular task to a registered dietitian but the randomly selected dietitian may not be practicing diabetes prevention intervention in the way we know it to be effective. So, if the dietitian has been trained in diabetes prevention, that bodes well for the outcomes. So, we have the CDC very interested in really offering diabetes prevention to the broad population of the country. And they have encouraged the training of lay persons to deliver diabetes prevention interventions similar to the one used by the United States Diabetes Prevention Program. And these lay persons, known as lifestyle coaches, are then licensed and registered to deliver these services across the country, typically in areas away from clinical centers or hospitals, so in the community. And several such people have been trained across the country, and physicians who are interested in referring people with prediabetes that they've recognized to join some of these programs can actually learn about programs near their location by checking the cdc.gov website.
Tell us how those lifestyle interventions actually work in terms of the outcomes.
So, in studies that were carefully designed, in which individuals were randomly assigned to the lifestyle intervention that I've just described, the elements of which I just described to you, versus usual care or placebo treated group, and then observed over time with the outcome of progression or non progression to type 2 diabetes, we are finding rather robust benefits. Depending on the study and the population in focus, we have expectations of about 30% to nearly 70% reduction in the risk of progressing to diabetes compared with placebo treatment. Along with the prevention of diabetes comes additional benefits. In the US Diabetes Prevention Program studies, we saw decreases across the board in several notable cardiovascular risk factors, decreases in blood pressure, increase in HDL cholesterol, decrease in triglycerides. And in other studies where the individuals had been followed for much longer, like decades, they are also reporting decreased incidence of cardiovascular complications, microvascular complications, and even all cause mortality.
So we know lifestyle interventions work, and in your review, you also talked about medication use, highlighting the use of metformin. Should I just start everyone on metformin at the same time that I start a lifestyle intervention?
That would not be a judicious approach from various perspectives. Based on the evidence, several medications that have been tried for quote unquote diabetes prevention have actually proven effective because the outcome measure is blood glucose levels. And many of these medications actually were originally approved for treatment of diabetes. So any drug that lowers blood glucose would appear to be effective in diabetes prevention. The problem was that when those medications were stopped, the blood glucose had a tendency to rebound back into baseline levels or above. So the drugs were masking rather than actually preventing diabetes. Now, metformin is a special case because it's been around for decades and there's great familiarity with its efficacy and adverse effects. And in the diabetes prevention program that we conducted, there was a group randomly assigned to metformin treatment for the same duration as another group that received lifestyle intervention. So we did have head to head comparison between lifestyle intervention and this particular medication with a control group that was placebo treated. And the results of that study did show that lifestyle intervention was robustly more efficacious in decreasing progression from prediabetes to type 2 diabetes compared with metformin. The actual numbers were like 58% relative risk reduction for lifestyle versus 31% for metformin. For that reason, it seems more appropriate to initiate lifestyle intervention as the preferred first line approach and see what happens before consideration for metformin. However, having said that, the current and recent recommendations from the American Diabetes Association particularly promote the use of metformin for diabetes prevention in people with prediabetes who fit certain criteria, such as those who are younger than age 60 years, with highish or high body mass index at the 35 kilograms per meter squared or greater level, or who had the evidence that they are halfway up the impaired fasting glucose scale. So remember, the impaired fasting glucose scale begins from 100 milligrams per deciliter to 125 milligrams per deciliter. And it was observed that those who already had reached like 110 milligrams per deciliter may have moved on, started marching on toward diabetes, and metformin was particularly helpful in delaying the progression. The same can be said for individuals whose hemoglobin A1C is at the 6% or greater level for a scale that ranges from 5.7 to 6.4 for the diagnosis of prediabetes. And lastly, we observed in the diabetes prevention program that women with a prior history of gestational diabetes were particularly responsive to the effects of metformin, and it had the greatest risk reduction in that particular subgroup. So, whilst we do not recommend medications as the first line approach, we do recognize that metformin may be particularly appropriate for certain individuals. I must caution that because lifestyle intervention at some level can be adopted by just about anybody, the use of metformin should not signal the abandonment of lifestyle intervention. Lifestyle intervention needs to be the foundation, the platform upon which we consider intensification with any medication.
All right, before we wrap up, are there any further points that you would like to communicate to listeners about prediabetes or what you think the future holds for society about this condition?
I think the promise of the future is an increasing recognition that the 96 million or so adult Americans who have prediabetes need not be observed passively as they transition to type 2 diabetes. And the increasing awareness and the increased effort to intervene promptly should help us redeem a good number of our citizens on their path to type 2 diabetes and bring it to a halt and possibly even reverse prediabetes to pristine normal glucose regulatory state. Currently, 1 in 3 adults in the US have prediabetes, as you've mentioned. Around the globe, more than 700 million people meet the criteria for prediabetes. Therefore, proactive steps in screening and diagnosing individuals with prediabetes would enable prompt intervention that should translate into improved health along with prevention of diabetes and associated complications. It is our hope that this becomes a priority among primary care physicians.
Well, thank you very much, Dr. Dagogo-Jack, for this discussion and your insightful comments about this very important topic of prediabetes.
Thank you, Dr. Simel.
This episode was produced by Daniel Morrow at the JAMA Network. The audio team here also includes Audrey Foreman, Mary Lynn Ferkaluk, Lisa Harden, Shelley Steffens, and Hannah Park. Dr. Linda Brubaker is the senior editor for JAMA Multimedia. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.